Welcome, everyone. We'll get started in just a moment. Welcome to today's webinar. We'll be starting in just a moment. We'll be starting in just a moment. Welcome to today's webinar. We'll be starting in just a moment. Well, hello, everyone. Happy Healthcare Security and Safety Week. My name is Heather Zemo. I am the Education Director at IAHSS. Welcome to today's webinar. Honored to serve on the patient care team sponsored by GHX. I'd like to cover a few housekeeping items before we get started. We will allow for time during the presentation for your questions. You do not need to hold off until the end. Please use the Q&A option on the bottom of the screen to submit any questions. Feel free to use the chat feature to introduce yourself, but do not put your questions in the chat. Please use the Q&A so that we can find them easily. This webinar is being recorded, so it will be available to anyone for free in the IAHSS store. With that said, let me get started by introducing our GHX sponsor, Nick Zasowski. Nick?
And hi, everyone. On behalf of GHX, I'm excited to welcome you to today's panel discussion. Again, my name is Nick Zasowski from GHX VendorMate, and I'm also the current vice chair of the Colorado chapter of IAHSS. And shout out to Felicia, our president. Just giving her a hello to the group. She's out there. I've been fortunate enough to work with and get to know many of you over the past few years. And I get to work in helping ensure that the vendors who visit hospitals are properly credentialed and compliant with the policies of your organizations. In some cases, I've also been able to support your health systems with our cloud-based kiosks and badging technology. We are pleased to support your efforts in helping hospital communities you serve stay safe and secure. I look forward to GHX's continued partnership with IAHSS and its mission. As we turn to today's panel discussion, as well as on workplace violence and this week's theme of teamwork, it's just a reminder of how our teams and culture extend beyond just our internal groups, and also includes the patients, visitors, and vendors that are also walking our hallways and including them as part of the solution. Today, I'll be introducing our moderator and panelists for the discussion on security's involvement in patient care. We'll start off with our moderator, Ashley Ditta, who has over 15 years of security, safety, and parking experience in the healthcare sector. Currently, Ashley is the Director of Public Safety and Parking Safety Officer at Newton Wellesley Hospital in the greater Boston area. Ashley currently serves with the awesome background there as our member at large for IAHSS, and is also the assistant regional vice president of Region 5F of As Is International. In addition, she has held the board and volunteer positions within the greater Boston area and Boston chapter for IAHSS and As Is, and remains active in both organizations. So thank you, Ashley. Next up, we have Dennis Himes. Personally, just want to thank Dennis for his help with our Colorado chapter and all of your support for us, Dennis. So thank you. Dennis is currently employed by Memorial Hermann Health System as the Director of Security at Southwest Hospital. He did share with us that is not his window behind him, but close to it. And he has direct oversight as a security officer. Sorry, I just totally reread the wrong line there. Dennis has been in healthcare industry for the past 25 years. For 14 of those years, he served as the hospital security officer with direct oversight of environment of care, safety, committee activities, survey readiness, and regulatory compliance. Other areas of management include environmental health and safety, transportation, and emergency management. And it's obtained a CHPA in March of 2021 and is a member of the IAHSS Houston chapter. Next up, we have Todd Miller joining today. And Todd is the System Vice President of Security for SSM Health, consisting of 23 hospitals and over 450 outpatient clinics across Missouri, Illinois, Wisconsin, and Oklahoma. Todd holds a degree from Miami of Ohio in secondary education and served as a special federal officer with the FBI St. Louis Division Safe Streets Task Force prior to transitioning over to SSM in 2015. Todd is co-chair of the Greater St. Louis Health Security Directors Association and a past contributor to the IAHSS Journal of Healthcare Protection Management. Todd speaks regularly around the country on such topics as street gang awareness and the healthcare environment, how to mitigate the impact of civil unrest on hospital operations, armed intruder response, workplace violence, situational awareness, and many others. Todd, the Colorado chapter is probably going to have to ping you to speak at our chapter with all those expertise. So thank you.
Yeah, we'd be glad to. Thanks for having me.
And then finally, we have Jonathan Acorn. Jonathan is the Director of Operations with Integrated Protection Services in British Columbia, Canada, where Jonathan oversees protection operations for the lower mainlands for health organizations. His responsibilities span four distinct health organizations across large geographic areas consisting of hundreds of facilities and over 65,000 employees. Jonathan has been a member of IAHSS for over 25 years and maintained a CHPA designation since 2005. Jonathan has served the IAHSS community in numerous roles, from chapter executive positions, working groups, to regional leadership roles. In 2017, Jonathan was awarded the Medal of Distinction by the IAHSS BC chapter and is currently a member of IAHSS's Threat Management Working Group. So thank you for joining us today, panel, and Ashley as our moderator. And Ashley, I'm going to go ahead and pass it over to you. Take it away.
Thank you so much, Nick. Hello, everybody. Good afternoon. I'm in the Boston area, so East Coast, but I think we've got a bunch of people elsewhere. So happy good morning and good afternoon to all. And most importantly, happy Healthcare Safety and Security Week to everybody. Hopefully you've had a really great week with your teams and are really honoring the work that they do. So I also just want to say I love the chat. We've got a lot of people making lots of comments, so please keep introducing yourself and bragging that you have program of distinction. I've seen that a couple times, which is awesome. And again, if you have any questions, I will be monitoring the questions in the Q&A section, not within the chat. So just as an FYI. And I also just want to say thank you to Nick and all of GHX for sponsoring this. So we're going to get started. Many of you might have seen this posted on LinkedIn and such, but in Paul Sarnese's article, Journal of Healthcare Protection Management, he wrote about a message TJC, so the Joint Commission surveyor, imparted on him that he's never forgotten. And this really touched me when I heard this, and this is what it said. When he oriented new staff and new employees to the hospital, he would say that the hospital and that the facility/hospital is the patient. And their job is to keep the patient healthy and keep moving the patient's quality of life forward. So it's our responsibility as healthcare safety and security leaders to ensure that our staff understand the importance of their duties and how their impact has on clinical outcomes and patient experience. So my first question to the group, and take it away, whoever wants to start, but how have each of you, let me start over. How have each of you in your role as a security leader in a time where workplace violence is the highest rates it's really ever been, aided your teams to come to understand that they are an integrated part of the patient care team. Looks like Dennis is going to start. I'm going to turn it over to you, Dennis.
Yeah, no, I got off mute as many times we remind everybody for that. And so, I like what you mentioned on the article, but really the introduction and onboarding of your security team is the first part to understand what you have to offer as an organization. And so from that, you look at what is our role as a security or safety officer. So as you mentioned, Happy Healthcare Security and Safety Week, it's 1 week out of the year, but our team, what I consider our everyday heroes, they do it every day, right? And so they're the ones on the front line. And so when you come into this role, if you've never done it before, what are the risks walking into the healthcare setting? And so while our premise is about workplace violence, and that has continued to escalate over time, I remember as my first role as a leader that workplace violence was a strange event. It just didn't happen that often. And the hospitals that I worked in would almost just stop altogether. You had your patient relations team, you had your risk manager, everyone came to find out what was happening with this patient because this is not the way it's supposed to be. 25 years later, here we are today. It's almost a common occurrence to see that. So how do you get to the point you're no longer desensitized, but each event is an actual event that you look at, you look for improvements. So you take your new officers coming in, you bring them on board, you educate them, you mentor them, and you bring them to a direction of what's important for them at your hospital or your healthcare system. And so I've always used the moniker, if you came to work uninjured, you go home uninjured. And so we want them to be safe every day, just like our patients, visitors, and employees. Thank you.
I'm going to turn it over to you, Jonathan. I think you're unmiked.
I'm unmiked. All right.
Unmuted.
So one of the most important things, in my opinion, is making sure your team and everybody understands the fundamental message, right? And the fundamental reason why we're here, right? For patient care. And it isn't just about just the patient. It isn't just about the facility. It isn't just about the staff. It isn't just about the officer. It's about everybody equally. If the staff don't feel safe, then they're not going to be providing good care, right? So how do you create a team that helps that, right? So when the officer shows up, the nursing staff, the clinical staff, the other staff, whomever, the patients should feel better. They should feel protected. They should feel safe, right? And that's kind of job number one. Obviously, I'm oversimplifying it, but it's one of the more complex or harder things to do. Is how do you achieve that buy-in from multiple levels across the organization, from your officers to your leaders of your teams to the clinical staff, that they see the protection officers as a benefit, not just a uniform that they call when they need to at the last minute, so a lot of things working towards that type of effort and you can't expect everybody to be true believers in the mission. Some people, it's their job, and some people have good days, some people have bad days, but if you can kind of achieve that minimum bottom line, kind of that minimum level of at least understanding why they're hit there and valuing what they do. If you want your officers to value what they do, you have to value what they do. Right. I'll leave it at that for now. But
Yeah. Ashley, I could probably expound a little bit on what Dennis and Jonathan both said. And to me, it's part of that onboarding when we are going through hiring and you're actually speaking to the officer and you're describing the job. When you're talking about the security industry in general, or a lot of our ex-military or law enforcement coming in, a lot of the time they're in that mindset of kind of black and white based on rule of law. Like we do X based on this rule, this law, and that's your outcome. And a lot of times that outcome is almost punitive from a legal perspective. And I think really messaging the minute they walk in for that interview that healthcare security is its own animal. It's its own separate part of the security vertical, where you have to have a compassionate bone in your body. You have to have that ability to navigate the gray area that is healthcare, where it might not be, you might not be looking for that punitive response. You might be looking for the end result that we're all driving for with our partnership with nursing, which is having that person leave better than they came in the hospital, and really talking that through the applicants and making sure they understand, that's our purpose, that's our cause within our department is important. And some people can't adjust, and there might be wonderful security officers that could work a government post somewhere where it's, hard line this or that. Whereas a lot of times I describe it as that gray area. And if you can navigate that, then you're going to be a successful healthcare security officer. So
Well said, Todd. Yeah, the gray area is what we talk about a lot, the black and white. There is no black and white in really life. There's very few things that are truly black and white all the time. Your comments about how some of the people that are attracted into the security industry sometimes from an enforcement type of background instead of a collaborative type care background, and it's easy for an officer to this is my job, I do this, and this, and we try to instill in that, well, here's your guidelines from left to right, and you can color within those lines to achieve the same goal, or kind of stay in there. But there isn't one way to do everything, right? Sometimes it takes a little time. Find creative solutions, understand the issues more, understand the staff's needs more, and sometimes that's maybe understanding the need more than the staff do at the time, right? And being that collaborative voice and finding more patient-focused solutions to a particular problem at the time. So living in that gray, really important.
Yeah, I always say when I'm interviewing staff, or thinking, I guess is a better way to say this, is that you can't teach customer service, right? You can make it better, you can improve upon it, but if they don't understand the mission that we are here and what we're here for, it's really hard to teach, in my opinion. But so could you guys give us an example of a program that your team has put in place to address workplace violence and some best practices that you believe your programs have?
Sure. So fundamentally, it starts with the departmental leadership culture and down towards the officers, and then the training and education of our security staff, trauma-informed practice, Indigenous cultural safety and diversity awareness. And this is on top of all the fundamental security issues and that, but understanding how the environment impacts others, how others impact the environment, and how your behaviors impact the people you're dealing with, et cetera, right? Understanding that and trying to keep that alive throughout the day is a challenge, but it's worth the effort. Ongoing mentorship of the security staff, being critical, not trying to catch them doing things wrong, but trying to find opportunities to learn from experiences that they're doing. Other things like threat assessment and management programs, right? So staff understand you're not just the guy that calls when they need a door open, or if they need help with a potentially aggressive person, right? That they have a greater level of support. Quality assurance, ongoing, retraining your officers. Trained and deployed is not done. Trained and deployed is basic, right? How do you continue growing their skills, their understandings? You send somebody through 10 days of training, and that sounds really great, and it's really a great comprehensive training program. But the students probably learn 20% of remember 20% of what you said, right? How do you keep reinforcing that extra 80%? So doing so in a sustainable way that doesn't, require, excessive resources to do, or builds resentment in the officers about, oh my God, I got to do this again. Finding ways to do bite-sized kind of pieces of information and reinforcing that, finding opportunities to reinforce as we go. And I know I'm talking a little bit more about training and stuff, but all of this supports that safer workplaces, All of it does, right? Data and analysis, right? Being able to make evidence-based decisions with meaningful, appropriate data, so you're not over or underreacting. Obviously, partnerships with your internal, external people, agencies, is so important. It's a very complex situation, but there's no one thing you do that this is how we support workplace violence or preventing workplace violence, right? It's nuanced and it's many layered, right?
I actually wanted to build upon a point Jonathan said about data. I think it's becoming more and more valuable, and it's more of a standard for our security programs to fall in line with the rest of our hospital constant quality improvement mindset. That it's looking at the data. It's like you said, John, making informed decisions. It took our organization a long time to get data integrity about workplace violence and really understanding the who, what, when, where things were happening. And almost in that kind of hotspot policing model of, if you looked at the campuses like a heat map, where you should be when, if your data is telling you that you have a window and all your events are happening between 8 a.m. and 9 p.m., which is for our organization kind of the hotspot. It's a very distinct plateau of our verbal and physical contact. And you say, well, what do we do about that? For us, it was hard getting out of the mindset of our shifts are going to be 3 on days, 3 on evenings, 3 on nights. And you go, well, that's not really addressing the problem. And again, shifting those resources with strategic priority to say, this is where we should be aligning all of these resources, because this is when it's happening, this is where it's happening. We even know, who's more likely to commit those offenses or repeat offenses. And so how are we taking that information, that data, turning it into actionable intelligence and actually deploying our resources just like our clinical teams do, the way to kind of flesh out error from the process. So what for us, just really helping our leadership teams interpret data, turn into intelligence, purposefully round through those areas, making sure we're contacting our clinical staff proactively before things are happening, is really becoming the norm. It has become the norm, and we've actually seen some great outcomes with that. And especially when you're getting that real-time information, you're in the unit, you're purposefully rounding, you're talking to the clinical staff, and they say, yep, you're here at a great time. The patient in 202 is starting to show signs of escalation. Now you're saying, okay, what are we doing about it? Now, what are you doing about it? Or what is security doing about it? It's what are we doing about it collectively as part of the patient care team to prevent escalation, and aligning those resources, bringing it back to the department for the next round of officers that come through, and on that real-time information sharing. So I think just data analysis, if that could be considered a program, if you were to put it in a box, for us is really starting to give us some good results, where traditionally I don't think we were doing as well with the data that was on hand to try to get positive outcomes.
Well, and just to add on to that, I probably, with Jonathan and Todd both, we're all in the same boat to highlight, what we look at. And so I already had some thoughts with that, Ashley, when you asked a question from the training perspective, and I think John did great to add to what Todd said with data. We live in that world, and nursing has been doing it for so long, so data informed decisions really is our next level. And not that it hasn't been there, but I know that in my connections with law enforcement, emergency preparedness, and a few other areas, we're always talking numbers, but what do those numbers mean? So Todd brings up some points with where are the events taking place, what time, and are we strategic on our staffing model? Think that's a whole nother discussion with labor pools and staffing that we all compete for that talent, right? But what I want to highlight is something that Todd alluded to with purposeful rounding. When you look at your relationships on the units, your high risk areas, that interaction is critical. Why? Because you're trying to develop that relationship. So, there's a book out there called The Speed of Trust. If you haven't read it, and I don't endorse that book, I read it twice. You would be amazed that once you've developed a relationship with persons, that trust factor increases 2-3 times. And no longer are you dealing with just an email for information. You're dealing with a phone call or a face-to-face interaction to make it better. So when our officers are rounding, it's intentional and there's a purpose for that, right? So they're trying to get to a level of not just reacting, but responding to the program. So when you look at that, how else are some of those data measures put in place? So as Todd mentioned, how do we do that for security, right? So some of you may have electronic systems with card access. You may have wanding systems for tours to show where was the security officer at that point in time? Was it safe at that moment? Was there an incident? I think we also look at that for accountability to say, hey, we've done 2 rounds in this area, 3 rounds. And so if you look at data, someone may say, what's the appropriate frequency? I could never dictate that. And if I produced a model, it would be wrong for your organization. And so there's so many factors to consider. But when you talk about just a few other things to go down that discussion point, what are some causes of the violence, right? So what can you look at? Is it through patient-based activities? Was it staff induced? Was it the environment? So with a patient, are there drug abuse issues, behavioral health issues? I can tell you from experience, without too long of a story, my officers, wherever I've worked, they have responded to different codes and they'll come back, man, if the nurse was just nice to that patient, this would have never happened. And I know all of you are shaking your heads on the call versus how do you work on that? So like Todd and John both say, that relationship then escalates those issues to the nursing leadership or program development. How do we train together? Like Jonathan said, how do we train together? And can you imagine the strength of nursing and security getting the same training at the same moment to deal with real world issues? Is it realistic? It could be difficult, but it can happen. So just one other thing with that, when you talk about it, whether it's non-escalation, de-escalation, all the way for the full spectrum, what are solutions? So not just talk about the problems, but what solutions can you come up with? And is it more training? Is it duress or panic buttons? Is it a standby by security? Does risk and legal have to be involved? And so I've seen a couple of times in my career where more than that, but just boundary setting with a patient. You know, some behavior is not tolerable. And then sometimes if it takes you down another path, organizations have to release the patient because of their disobedience to the medical care plan, not respecting staff. And that's a sad day, right? Because where else are they going to get health care? They'll have to go somewhere else because of the threats that they continue to bring in the medical care setting. So there's a lot more to that. I know I highlighted a few things, but when you're talking about problems, talk about solutions, and then an integrated approach is security and nursing at the same table, right? So while we have different pay in the organization, that care plan, you know, we're honored to be a part of the patient care team because that's our theme this week. We're a part of that process. They listen to us, we listen to them, and then we move forward with a better, safer environment. So those are kind of things I'd like to highlight.
Yeah, that's a good point. We're putting efforts into with the implementation of kind of a relational security model here. We're really putting efforts into empowering our officers to have a voice, right? And an appropriate voice. So
yeah, that's great.
That. Many of our, traditional models have been utilizing contracted security officers, and we're shifting that to an in-house model. And these individuals were conditioned to just do what they're told, to be seen, not heard, and that's not right, right? Like the security staff, they have valuable contributions, and them understanding what the clinical needs are and what the pressures are, and clinical staff understanding security's perspective and role, that's really important. So we're implementing kind of regular connectivity with our security staff to team huddles, especially in areas like our emergency departments, our mental health and substance use areas, areas that we know traditionally are more challenging. and our data helps inform that, right? And data isn't just about, did an incident happen? It is, of course, did it happen? What was it? What were the influences on it? Time of day, temporal studies, all those kind of things, and understanding looking at the data from more than one direction, right? You have to look at, because there's lies, damn lies, and stats. And then you can you can look at it one way and you can manipulate the numbers to present a case, right? And then somebody else can take those same numbers and say, well, it's this, right? So you have to look at it objectively from different perspectives. And understanding kind of how what our customer needs are, right? If you want to put it that way, a customer, the clinical team, understanding that, well, this is how it is in this type of unit, and this is how it is in the emergency department, and this is how it is in behavioral health units. They're not the same, right? The staff needs are not the same. The last several years, and I'm going to try not to use the P word that we've all globally been through, but managing fear and anxiety has always been part of what we do, right? It's been a huge part of what we do. It has never been more challenging than it is now, from my perspective, at least. The last several years have really strained the patience and tolerance of everybody in our society, anywhere from financial pressures to staffing pressures. Healthcare staff don't seem to enjoy the same level of regard from the public that they used to. Here in Canada at the beginning of the COVID outbreak at 7 p.m. every night, people were out on their steps pounding pots and pans and making noise, kind of in thanks to the healthcare staff. Then something changed and that stopped. And then we'd start seeing people venting their frustration on the target in front of them, which is the nurse, who is just there to help them, right? And they're somehow blaming the healthcare system for, the larger issues, right? Staffing levels have never been shorter. The opioid crisis, right? These pressures, just more and more and more and more pressures, where, at least anecdotally looking back at it, it always feels to me that tolerance was higher in the past than it is today. And that isn't, if you look at data, that's objective, it's evidence-based. And then there's what do they say? How do they feel? What's the anecdotal stories being told? You can't ignore those. You can't look at data and say, well, that's not true. The data says this. Now, anecdotal feelings about a site, about how safe they are, you need to listen to that, right? You can't ignore how the staff feel. One person's feeling of safety, if they don't feel safe and somebody else does feel safe, nobody's wrong, right? Your feeling of safety and security is just that, it's a feeling, right? So we can't ignore that side of things. And you don't want to go down rabbit holes or changing your program because somebody tells you a story. And I'm not saying that, but I am saying listen to the people and understand where that's coming from. And maybe that data can help provide them some clarity, and maybe they have information they never had before and they feel a little bit better. Maybe the presence of your security staff who are talking with them as people, right? Who are trying to understand, who are regularly there. They're not seeing just the uniform anymore. They're seeing, Joseph, the officer that's there to help me, right? There's a lot of things we can do, but today, I've been doing this 30 years and this is really challenging today, and we can't ignore certain things, and we can't sit in our old paradigms and figure out, well, this is how we've always done it. And let's, data says this, and we're going to do that, right? We have to use every tool at our disposal. Yeah.
So I'm going to sum up some stuff, and then please jump in. So what I'm hearing from the three of you is data analysis, right? Communication, bringing that back not only to the patient care team, the clinical staff, but our own public safety staff and security staff. The speed of trust. I put the link in the chat webinar as well. So I have not read it. It's on my list now. Being proactive versus reactive, which is, something we all strive for regularly. Training together, clinical, non-clinical, as a team, and what we can learn from each other. psychological safety, which no one mentioned specifically, but I think that that's what we're talking about. Why is that nurse doing something? How is she or he responding? And how can we communicate with that nurse to have them understand their role, but in a psychologically safe environment? Solution-based approaches, an integrated approach, empowering our officers to have a voice, not just be reactive, implementing high-risk safety huddles, team huddles in high-risk areas, and then never underestimating the importance of pairing our quantitative data with our qualitative data and bringing that home. Do you guys have anything else to add, or would you like me to go ahead, Todd?
Yeah, I think one thing that I want to be, a little bit transparent about in my organization that we have had, I wouldn't say a struggle, but it's been a journey for us, let's say, is the role of the security officer. There was a lot of report taking that was very, I would say, what based. So what happened, factual report dating, almost if you were to equate it to a patrol officer showing up on a scene and just taking the facts. When this happened, the nurse was hit on the left side of her face with the suspect's right fist. Very, very factual incident reporting. And one thing that we are really trying to empower our officers with is more the why behind it, and having the conversation with either the victim or the witness to say, okay, I understand, this happened. Do we have any indicators of why this happened? And sometimes you'll get, well, it was a spontaneous act. Okay, that does happen sometimes. But really taking and putting on the kind of the investigator hat, the detective hat, and saying, did anything happen within a half hour that may have escalated the patient? Did they not get lunch on time? Did they want a cigarette? Did they find out that they're not going to be discharged before the weekend? What is it that something made this person, I shouldn't say all the time, but most of the time, escalate to the point of physical violence? And looking all the way back to, was it how they woke up in the morning? Or was it, like Dennis had mentioned, was it maybe just a relationship issue with a clinical worker that just isn't the right rapport? And really just trying to dig into that, bringing that back to the department, and then partnering actually with the clinical worker to say, what is going to be our new plan of care to prevent another act, another victim of walking in? And if it's the person, didn't get a cigarette or was denied, nicotine gum or something, what is it that we can do to proactively get in front of the next incident? And so I think that's been a challenge for us, but we're getting there. We're getting much more in our workplace violence prevention log, which is kind of an ongoing real-time tally of what happened, how we're going to prevent it, any barriers to that prevention. Things like that is what we're really trying to empower officers and asking those questions. And sometimes it's difficult to ask the question, especially to a victim. What may have been the pre-indicator to this that we could have prevented? So I think that's another thing that we're just trying to do, again, to get in to the left of the bang, if anybody knows that, another good book, to really prevent the actual physical contact from happening, and really focusing on that proactive approach using data as well. So.
And just to add to that, Todd, some of the things that we've seen, and I've seen not only where I'm at today, but in the past, is sometimes a shared relationship with your patient relations teams, because some organizations treat that as the first response when something goes wrong, right? And so you're constantly chasing good information. You also have cultural barriers, everywhere you go. Not only is it just the language, but the eye contact. So while you and I may feel comfortable with eye-to-eye contact, that may be a threat to another culture, or close proximity. So you have the diversity that you have to deal with, our experiences and our roles, their experience coming in, the fear, the anxiety, at the end of the day, with all of these different things, if you have another question, Ashley, we'll be ready for it, is just the outcomes that you're expecting, right? So purposeful rounding, use that in a lot of organizations, and you're really trying to get staff engagement, you're getting open dialogue, you're looking for trust, right? You're looking for confidence in the staff. I think even Jonathan mentioned it. Patient care providers need to be given patient care and not be thinking about all these other things. I was working in a hospital where a father was peeking in the surgery rooms because his son, who was a burn victim, was having surgery. And he was going around, I don't know how he got there, but he was able to get in. And I met with him, our other team members met with him, and he was very scared for his son. And so he was making threatening remarks related to that. And this one thing I shared with him then, it was many years ago. I said, hey, if you're busy threatening our care team, how can they focus on your son to give the highest level of care? And so we were able to de-escalate that situation, but sometimes we can't, right? But going back to my original comment, we're expecting to support that patient care program, to be a part of the team. We want staff retention to improve. This nursing exodus, I even have security at some locations in the past where they didn't want to work in healthcare anymore. I'll save the COVID-19 discussion for another date, but people didn't want to be there. Their families were more scared for them than they were, right? So we lost them, but we want to build that relationship. We want to enhance it, keep it open, improve the intentional aspect. It's not just a security officer coming through and being visible, right? It's an intention. You're stopping to get to know them, first name basis. I think Jonathan even mentioned that, first name basis, how do we get that? So the integration of all that, while it's not perfect, it is one thing that we can do to improve and look for those expectations along the line. Because at the end of the day, we want a safer environment, right? The patient's there to get the care. I don't know that we have enough behavioral health facilities to handle those crises in our community. We all know law enforcement is always fighting to find the right law enforcement officer to handle the community crisis related to that. And then their job are not crisis responders, but guess what? They are out in our community. If you remember the old policing model, you had your policing that was taking place and they lived in the community and they were working with everyone. So if you take that and you use some of it at the security level, we are community policing in our role, not to threaten, but just to be there. Hey, what can I help you with? And so those engagements with visitors and patients, and even though we're rounding with nursing and the leaders, the patient rounding is also important too. We can contribute to that, to good, sometimes negative because of the way the patient felt. But if we can work together on all these things, we can accomplish a lot more, and you can measure that too. Is it a guarantee?
No.
Maybe not, but there's no guarantees we have in life, but our proactive response is always one we want to sit back and say, here are the things that we are doing. Here's what we're expecting, and use the data, use the analysis, understand it's not scientific, but it does help us give decisions of where we want to go in that purposeful rounding intentional process. And I think we're better off because of it when you have them.
So one of my questions would be, we've been talking about purposeful rounding, integrated teams, community policing, however whatever term you kind of want to use. What have been some benefits and outcomes that you have seen within your hospitals and your systems once those processes have been implemented?
Could probably speak to that a little bit. I wish I could say that one security process or something that we've done to try to combat workplace violence has been what has brought our organization some success. This year, our DART rate is about a 1/3 reduction. We've had a lot less physical contact, indemnity, medical. We've seen a steady decline over the past couple of years. But I think it's kind of the sum of all parts with clinical, some of the things that clinical has done as well. And again, it all comes back to right communication and having them understand, if we don't know, we can't help. If you don't report it, we can't help. If you don't even put in those pesky verbal threats, we don't know where these things are happening. We can't align resources accordingly. So I think for us as an organization, I would say just making sure that we're notifying all staff of risk of violence. So whether that's an indicator on the door or a special colored call light or whatever it is that notifies everybody that the person in this room is a higher risk for violence against you is a big step forward. That was a big change for us. But again, we're still going to provide the same level of patient care. Disclaimer, always, right? But at the same time, just making sure that we're putting the right mitigations actions in place to make sure something doesn't happen to the next person that walks in the room. For us, again, it was data analysis and getting smarter about what we do and how we use our resources, workplace violence pass down logs, that real-time data, and really also empowering our clinical staff in escalating any kind of feeling. And like Jonathan was mentioning, and Dennis, the idea that they feel unsafe. Well, what is it that makes you feel unsafe? Call us, rather have than not, and not need than need and not have. We can always turn around and go back to patrolling somewhere else. And just that idea of don't let it be the end of the incident that we're finally being notified, proactively if you feel unsafe, having that kind of see something, say something mentality to, get the officer moving towards that location. And if we're not needed, great, best outcome. If we are needed, we're there in the beginning of the incident where the severity is hopefully much less than 20 seconds later, where we know seconds matter in an assault and that severity is much higher. So I would think just collectively, clinical and security's partnership in some of these workplace violence processes and new lines of communication has been our success.
Next slide. From our perspective, it's kind of re-emphasizing a lot of what's been said already this morning, but the idea of purposeful rounding, a relational security model, and really focusing or emphasizing our security staff's efforts on regular and intentional connection with our clinical teams, integration into the clinical teams, and knowing how to appropriately integrate with them. When, coming up to a nurse and asking her, how's everything going today and all that. If you pick the wrong moment, you're all laughing because you know what I'm saying. But it's getting that timing and building that kind of understanding how to speak the language of that department. Right? A maternity unit may be very different than a mental health unit, than an emergency unit, than a medical unit. So learning those kind of nuances and how to provide the support and the service that the specific unit or area needs, right? And that's more art than science, right? But ultimately, that continued sustained effort, connecting in with the clinical staff, the purpose of that is to reinforce that fundamental mission, the fundamental reason that our programs exist, which is to provide for a safe and secure healthcare environment, right? And I don't want to try to use too many cliches here, but everything starts at the very, very bottom. Every little, the first little brick you lay is, supports the larger structure. Your leadership downwards, your frontline upwards, all of these kind of things. So, and the officers then will achieve a better understanding of what the clinical people experience. Most people tend to experience what's in front of them through their own perspective, their own lens. I'm a security officer, so I look for security infractions. I look for people doing bad things. Not necessarily I'm looking for what's causing somebody anxiety, right? And if we can shift that focus, and our really distinct hope is that by really putting a lot of effort and emphasis into this, is that when a nurse or a staff member, I keep saying nurse, there's other people, it's the staff, when they see that uniform, they should feel a little bit better. That's really, if we can achieve some measure of success there, I think that would be really significant. And I'm sure it happens, and I know it does happen, but if we can improve that, right, increase that, if we can get the officers to fundamentally agree or feel a little bit more passionate about what they do, understand that they really are there supporting patient care. I'll borrow a comment from a colleague, Jeff Young. Everybody, I work in healthcare. I just happen to focus on security.
I like that.
That's a good one, John. And just to add one moment related to that, to connect what you said, John, and for Todd, there's probably multiple reporting mechanisms besides email, texting, phone calls with events, right? And so you have this slew of data and information you're always wrangling. What's the right direction? Did enough people get notified? We know as an industry, this is underreported. I know the times I've met with nursing, it's been difficult at times because, you know, you have occupational reporting and the OSHA reporting, you have some databases that the information is protected, but you have your security information, right? So you hope, like you said, Todd, getting to the intent, you know, what was the why behind that from all the different reporting mechanisms? And so if you as leaders, or we as leaders, develop that relationship with the units, what I've tried to do is do some other real-time follow-up with injury reporting. I'm on those special lists, probably like you all, this employee on this unit. So you try to see if can you meet with them. So post-event follow-up with the victim, no matter what it is always good if it gets reported, right? So now we're still talking about reporting. That confidence that you give that employee from an event that occurred within the last couple of hours or the last 24 hours, they'll talk about that to their coworkers, their other leaders, and they'll say, yeah, you know, well, this event may have occurred X, Y, and Z, but our security team or our administrative team came by and they met with me. I got a free lunch pass or I got a day off. You know, that maybe seem trivial, but that confidence, that trust, because we know we can't be everywhere at once, right? I mentioned earlier, if you come to work uninjured, you go home uninjured. That's just the way it should always be, but that's not always the case. So how do we build that on a day-to-day concept that we can't be everywhere at once? We'd love for everyone to not ever have anything happen, but we know that's not realistic. It's kind of like the schools reporting, hey, we had 0 shooting incidents during COVID. Well, no one was in the school, so you're going to have 0. So that's not data that's actionable, right? It's about the report. It's about the confidence, going to town halls, doing safety surveys, whatever those things may be, to extract it and then take action. And I know some organizations, if they're nimble and agile, they can move on it very quickly. Some are more bureaucratic. I've worked for some bureaucratic organizations. They're so large, you can't move fast enough because of what's happening out there. But we're at the local level, right? So we're part of that care team. It's not just nursing, it's all of us. And so I think the relationship piece, the trust, getting to know your leaders, they get to know you. In a moment, you can help out for real-time plans to create safer environments. And I think that's our end goal with all of this, what John said, what Todd said, things that have been in the chat. You know, Ashley, you've helped us with those. So do you have anything else for us? I know that we're probably getting close to time for our viewers today.
Yeah, there's actually a lot of great chat questions about, you know, who you're training, how do you get your leadership to buy in? There's some really good ones, but one of the things I really like, Amber made a comment, and I think we could all attest to this: trust is built in droplets, but lost in buckets. So I think I'm gonna steal that, Amber. Thank you very much. So one of I think my last question that I'll ask, and we have 6 minutes, would be, how have you guys been able to leverage your team, their diversity, right? We have people coming from military backgrounds, law enforcement backgrounds, corrections, sales, customer service environment. How do we leverage that to be able to improve the patient care team as a whole?
I think first off, you have to be open-minded. You can't, if you get stuck in the rut of, we do it this way because we've always done it this way, or we do it this way because I'm the director and I've decided how we're going to do it, and that's it. Then if you do that, you lose the opportunity to get creative, right? I know this sounds a little soft, but being able to have an environment where people feel confident and safe to express their opinion or provide their input is really important. It's a fundamental on debriefing, right? It's a safe space, you know, that kind of stuff. And it's easier said than done. I understand that. But when you integrate your team more fully throughout an organization or the people that we're there for, and you empower them to do so, right? Their opinions, their experiences, their interpretations of things will come through. And sometimes that'll be good. Sometimes maybe it'll be contrary. Who knows? People are people. They're messy, right? But I think if people understand the fundamental reason of why they're there, right? Safe, secure healthcare environment, staff should feel better by their presence, those kind of things. If they understand that, if they buy into that, their experiences will enhance it. If you will.
Yeah, and John's right. We could elaborate even more, but we'd run out of time, of course. It starts with that onboarding. So like here and everywhere else I've been, as you mentioned, Ashley, there's a diversity of experience coming into the healthcare setting. Todd mentioned the uniqueness that's here. It's its own animal. It's its own pace. It's its own volume. Each campus has its own culture. But if you take those different experiences and bring them together, what's our mission? Why are we here? What are we trying to accomplish? Now, obviously, as leaders, we're like a lot of folks where we take the high level overarching goals and they cascade down to the frontline officer. What is it in for? What's important to them? What's in it for me? The WIFM model. If they understand that, whether it's corrections or someone in the oil industry or first-time officer. I like the first-time officers because they have a clean slate. I don't have bad habits I have to work through, right? We get to establish it straight on. And hopefully our habits are not bad habits, right? So it makes sense to the organization. And so you take all that in place, grow from that, leverage the training, leverage the continual shift briefings, the logs, the data analysis, and it's just a constant improvement process that goes up and down, but we're always moving forward, and that's the goal. And some people are able to handle it, like Todd said, and others you don't. You either manage up or manage out. And so I think if we stay true to that and it being consistent, we as leaders bring that consistency to the table for those safer environments.
Todd, any last comments you'd like to make?
No, I think, they summarize it perfectly. And I think the only thing I could probably offer is just a more practical application of the idea that certain people just jive with other people better. And, one of the things that we do whenever we have somebody that we call preferred customers, that are a little bit more of a challenge while in our environment, if they cannot build a rapport with this officer or this clinical worker, it's the tap out, send the next person through. They might not like them either, then the next person. And then eventually you find that person, whether it's the way they look or how they talk, or who knows, there's something about them that all of a sudden that preferred customer all of a sudden just clicks with it. And that's the person. That is your conduit for de-escalation. It's your conduit for information, and really taking the time and not forcing the rapport in some instances where we've seen that just creates more escalation. But it's coming naturally. And it's like in any other aspect of life, you're going to have different people, different backgrounds and perspectives that some reason they just immediately click. So I think just back to your original question, for us, that would be something that, again, we're trying to change that culture as another tool in the toolbox. So if it ain't working, call the next officer in, call the next nurse in, and find that rapport. So
awesome. So I want to end today's by making two comments. The first is Todd Miller did he has an article in the Journal of Healthcare Protection Management about purposeful rounding. It's in volume 36, book 1. So if anybody wants to learn a little bit more about that, I would highly recommend reading that article. And then I think what Jonathan, you said, I know you borrowed it from Jeff Young, but I think it's kind of a nice way to end today. Could you repeat his comment about healthcare versus security?
We all do patient care. We're all part of the patient care. It just happen to focus on security.
I like that.
Yeah.
Thank you so much. I just want to say again, thank you to the three of you for sharing your perspective and wonderful experience and knowledge. I want to thank everybody who joined us today, and hopefully a lot of people who will be streaming this at a later date. A lot of great discussion, and most importantly, happy Healthcare Safety and Security Week. Stay safe.
Thank you, everybody.
Thank
Thank
you,
you.
everyone.
Thank you,
Good day.
Ashley. Thank you, Heather.